I'm Dr. Robert Kane, the President and CEO of the American Association of Colleges of Osteopathic Medicine. I want to thank you for joining us as we begin our journey to examine the impact of racism and injustice on healthcare and healthcare education in the United States. When I first became CEO of AACOM a little over 1 year ago, the most common questions I heard were, what is your vision? Or what is your plan? My answer always seemed to take some by surprise. I don't have one. It was an honest response. Although I had ideas, I did not have a plan. I knew the plan would come with time. I knew I had some listening to do and needed the help of others before a plan could be described for the organization. The same is true about this topic. Years ago, when I was leaving my internal medicine residency to begin my fellowship in pulmonary medicine, a mentor from the faculty offered an important piece of advice. If you ask the right questions and listen long enough to the patient, they will eventually tell you what's wrong with them. He talked about his outcomes being good not because of his knowledge or technical ability, but rather his listening skills. He reminded me that it was important to always start at the beginning, to avoid anchoring bias and diagnosis momentum. That advice served me well when I was in patient care and as I transitioned to administrative and leadership roles. I simply don't know enough today to presume to describe a plan for us to address racism and injustice in healthcare and healthcare education. I'm suspicious the same is true for many of you with us tonight. The learning must begin somewhere, so why not let it begin here and now? I'm committing to a series of meetings like this one. This is simply the opening of a conversation that will more fully develop, I hope, over time. During future meetings, I invite each speaker with us this evening to dive deeper into the domain that they will introduce as part of their panel. The domains have been chosen to help us see racism and injustice in healthcare and healthcare education more holistically, considering, if you will, the mind, body, and spirit of the issue. We will examine the impact of racism through the eyes of the learner, the healer, the educator, and consider the impact on society and mental health. In addition to the conversational forum, we are promoting the formation of an adaptive work group to be supported by AACOM liaisons to the Council on Diversity and Equity. Like our other adaptive work groups, addressing use of technology to transform medical education, rethinking clinical education, evaluating pathways to medical school and residency, and student roles in the COVID-19 pandemic response, it will be problem-based. The members will be asked to peel back the curtain covering the assigned challenge, to identify key problems, ask tough questions, and describe possible solutions to move us forward. Members of the adaptive work group addressing racism and injustice in healthcare education will be using these conversation forums to gain insight into this community and using that insight as they help me to describe a path forward for AACOM and osteopathic medical education. The work groups are made up of individuals who choose to participate, not simply those who are chosen. They're asked to consider realities and to determine what we can do with the resources available to us today and what we could do with additional resources. It is likely we can do more working together with other organizations sharing a common goal. So we are thinking about and connecting with others outside of AACOM and the osteopathic community. Finally, in November of 2019, before our current challenges arose, AACOM committed to addressing diversity as part of its strategic plan. I recognize that diversity and racism are not the same, but they are related. We have pivoted since the start of the pandemic to consider diversity as a lens through which we view all of our work, not simply a series of projects or plans to be completed and checked off. In a recent AACOM statement, I suggested racism is like an incurable disease, failing to respond to treatment. As physicians, we may not be able to help an afflicted patient today, but we don't give up on trying to find a way to help the next patient with the same problem that we will see tomorrow. With this in mind, we have titled this panel and our journey, Finding a Cure. But I am under no illusion we can accomplish something that so many before us could not, particularly if we act alone or are unrealistic about our goals. I'm looking for that first small win upon which we can build and feel good about the progress we've made. Tonight, we have individuals from other healthcare professions and other organizations to join us, hoping that such an interprofessional and interorganizational approach will help us to see a bigger picture, to recognize biases, and to avoid groupthink. On behalf of the osteopathic medical education community, I thank the 5 speakers with us tonight and look forward to the journey ahead. We are hoping you and others will become part of it. Our plan is to have each panelist speak with you for no more than 15 minutes. We will hold questions until the end, but do ask that you post questions and comments into chat for us to monitor. When all of the speakers are finished, we will have a Q&A to close out the evening, and you will receive an evaluation to help provide us feedback. Now, I would like to introduce your moderator for this evening's event. Dr. Marcine Pickron-Davis joined the Philadelphia College of Osteopathic Medicine in 2017 and serves as the Chief Diversity and Community Relations Officer. She is charged with providing the vision, leadership, and execution of diversity, inclusion, and community partnerships across the Philadelphia, Georgia, and South Georgia campuses. At PCOM, Dr. Pickron-Davis has focused her work on advancing the institution's goals for embracing diversity and inclusion into the culture of the college. This work includes leading the college's stakeholders in the creation of the 2025 Institutional Diversity, Equity, and Inclusion Strategic Plan, spearheading initiatives that introduce faculty, staff, and students to LGBT inclusive healthcare, cultivating a network of strategic partners and collaborators around health equity and community outreach, and providing leadership as co-chair of the Council on Diversity and Equity to the American Association of Colleges of Osteopathic Medicine constituent groups in their efforts to promote, broaden, and improve osteopathic medical education and the profession. She completed her bachelor's degree from the Pennsylvania State University and her master's of social work degree from Temple University's School of Social Administration. She earned her Doctor of Philosophy degree in educational leadership at the University of Pennsylvania. Please welcome Dr. Pickron-Davis.
Thank you, Dr. Kane. Good evening, everyone. It is my pleasure to serve as the moderator for this panel discussion, where we will examine and wrestle with the theme, Finding a Cure, an open discussion on racism and injustice in the American healthcare system. Over 700 of you have registered to join us in a conversation with our panelists who bring a diversity of perspectives in medicine, mental health, and well-being, illustrating the connections of the mind, body, and spirit, the central tenets of osteopathic medicine. We hope that you will find the conversations robust and productive. This discussion is intended to be the beginning of several conversations, as Dr. Kane alluded to, on racism and injustice in healthcare. I appreciate the leadership of AACOM and Dr. Kane in bringing racism in medicine at the center of their strategic plan and ongoing priorities for the organization. AACOM is well poised to lead transformational change across the osteopathic community. We have assembled a group of experts who offer an interprofessional lens and a space for a holistic conversation about the complexities of finding a cure on racism and injustice in healthcare. Joining us are, in their order of presenting, is Chantel Thompson, who is a fourth-year Doctor of Osteopathic Medicine and Master of Public Health candidate at the Philadelphia College of Osteopathic Medicine. She is the 2021 Student National Medical Association National President-elect. On On our medical school campus, she has advocated for increased cultural competency within the medical school curriculum by creating the PCOM Cultural Competency Program and founding the inaugural Cultural Humility and Medicine Symposium. In addition, she has advocated for diversity and inclusion as a past member of the President's Diversity and Inclusion Council, and most recently has been appointed to serve on the PCOM President's Commission on Racial Justice. In response to the recent calls for increased diversity, inclusion, and racial responses on campus, Chantal remains committed to work which diversifies the face of medicine and addresses health disparities in underserved communities and creates clinically excellent, socially conscious, and culturally competent physicians. She will offer her perspectives as a learner in medical education. Our second panelist is Dr. William McDade, a board-certified anesthesiologist and the Chief Diversity and Inclusion Officer for the Accreditation Council for Graduate Medical Education. In this new role for ACGME, he leads its mission to increase physician diversity and ensure inclusive clinical learning environments for our nation's residencies and fellowships. A medical educator, Dr. McDade previously served as Executive Vice President and Chief Academic Officer for the Ochsner Health System in New Orleans, which is Louisiana's largest nonprofit academic multi-specialty health system. In addition to serving on Ochsner's, I hope I'm pronouncing it right, executive leadership team, he directly oversaw the system's undergraduate, graduate, and continuing medical education and allied health programs and shaped its research agenda. Dr. McDade has been a champion for the elimination of health disparities and for diversifying the medical workforce. In 2016, he was elected to the Board of Trustees of the American Medical Association and currently serves on the Equity, Diversity, and Inclusion Advisory Committee. Dr. McDade will share with us his perspective as a healer. Next is Dr. Barbara Ross-Lee, who is a nationally recognized expert on health policy issues and serves as an advisor for both state and federal governments on primary care, medical education, and healthcare issues affecting minorities, women, and rural populations. In 1993, Dr. Ross-Lee became the first African-American woman to be appointed Dean at Ohio University's College of Osteopathic Medicine. In 2001, Dr. Ross-Lee was appointed Vice President for Health Sciences and Medical Affairs at the New York Institute of Technology, and in 2002, she became Dean of the New York Institute of Technology's New York College of Osteopathic Medicine in Arkansas. During her tenure, Dr. Ross-Lee built the college into one of the largest and most respected medical schools in the United States. She believes that medical education is a collaborative enterprise between teachers and students, which in turn influences the interaction between doctors and patients. She has lectured extensively and has published more than 30 scholarly articles addressing a variety of medical and healthcare issues. Dr. Ross-Lee will discuss the impact of racism in medical education. Following Dr. Ross-Lee is Dr. Darla Spence Coffey, who serves as the President and Chief Executive Officer of the Council on Social Work Education. The Council on Social Work Education is the National Association for Social Work, representing over 800 accredited undergraduate and graduate programs of professional social work. Through its programs and initiatives, the Council on Social Work Education promotes emerging technologies, interprofessional education, and innovative models, pedagogies, and practices to advance social work education. As the voice of social work education, the organization works to strengthen the position of social work within higher education, the national political environment, and in the perceptions of the general public. Dr. Coffey has an extensive background in social work practice in the areas of mental health, substance abuse, and domestic violence. More recently, she has been advancing the causes of provider well-being and leadership in presentations and writings. She will offer her perspective from a social work educator lens. Our final panelist is Dr. Bryant Smedley, who serves as the Chief of Psychology and the Public Interest and Acting Chief Diversity Officer, where he leads the American Psychological Association's efforts to apply the science and practice of psychology to the fundamental problems of human welfare and social justice. A national thought leader in the field of health equity, Dr. Smedley was the co-founder and executive director of the National Collaborative for Health Equity, a project that connects research, policy analysis, and communications with on-the-ground activism to advance health equity. He is also co-director of the Robert Wood Johnson Foundation Culture of Health Leadership National Program Center. He has published extensively on racism and health inequities, social determinants of health, healthcare disparities, and diversity in health professions. Dr. Smedley will focus his discussion on mental health and well-being. I will now turn the program over to Chantel Thompson.
Thank you, Dr. Ficaron Davis. I'd like to thank everyone for having me here tonight. And what I'm going to talk about is the impact on the student learner. All right, so my name is Chantel Thompson. As Dr. Ficaron Davis mentioned, I am the National President-elect of the Student National Medical Association. The Student National Medical Association is the largest student-run organization in the United States that is completely dedicated to the needs of underrepresented minority students. Our mission includes supporting our current and future underrepresented minority students, addressing the needs of underrepresented or underserved communities, and increasing the number of clinically excellent, culturally competent, and socially conscious physicians. So as we continue this conversation in looking at the learner and the impact that racial biases and social injustice occurs within the student learner, I want to take the time to explore a couple of student cases. So as you listen to these cases, try to feel what these students are feeling and come out of these cases with some questions that you would want to ask. So the first case is a 24-year-old African woman who presents to her second-year didactic course. She experiences racial bias when her professor teaches that sickle cell anemia and HIV are Black people's diseases. She rates her discomfort as a 10 out of 10 and experiences mild palpitations as she sits throughout her lecture. Past history includes a lack of instruction on the socioeconomic factors which influence health disparities. Our second case is a 29-year-old Black woman who complains of and experiences anxiety following an encounter with her professor who tells insensitive jokes about Black patients and women. She attempts to provide insight to the professor with no relief. Instead, she is told that students these days are just too sensitive. Past history includes a classmate stating that she was only accepted because of her race, and a lack of institutional response after reporting a separate incident involving another faculty member. And our last case is of a 29-year-old African male who presents to his clinical rotation during his third year of medical school. Upon examination, the student is instructed by the physician to tone down his Blackness, and the preceptor diagnoses the student's accent as being unprofessional in a clinical setting. As the only Black male in his class, he's had difficulty looking for support and encouragement, and the student now experiences an increased allostatic load due to his struggles with acclimating to the medical educational environment. So with these three cases, we want to explore is the fact that our medical students within our osteopathic institutions are not immune to the systematic racism that occurs within our patient populations and within our communities. And many of our students, when they experience these things, do not feel supported by their institutions. So what we want to do is really take some time to think about what those experiences are, how we can make a difference within these experiences, and how we can really make a difference just moving forward with this conversation. So first I want to talk about the unique burdens of the underrepresented student. And the first one I want to talk about is the feeling of isolation that many of our students have. So when we look at these, first is thinking about the actual total matriculants by race and ethnicity within our osteopathic institutions. You can see on this graph that, and I apologize for the small data, that first off, when you look at our Hispanic and Latino students, they represent 6% of the total population of matriculants. African-American students represent 3. And unfortunately, when we look at Pacific Islanders and Native American students, the numbers are so low that on this graph that I was able to generate, it comes up as 0%, which is lower than 1% from what the graph is able to show. And these feelings of isolation not only perpetuate, derives from the fact of, these feelings of isolation basically derive from the fact of not feeling like there are any other people in these institutions that look like us. And it causes our underrepresented minority students to feel excluded, invisible, and of poor fit sometimes when we look around and do not see others who look like us. And we know that a sense of belonging in an institution is an essential part of success and satisfaction. And a lack of feeling like you belong really perpetuates the feeling of imposter syndrome in our students. So next I want to talk about the number of African-American male students within medical schools, which is one of the lowest and more disheartening statistics that we have. And this data comes from the AAMC. Within the last few years, despite the fact that in the last several years, African-American males have increasingly been graduating from college at some of its highest rates than in the past, and that the number of matriculants or applicants have actually increased in the last few years. The number of matriculants actually are at as low as it was in 1978. Which makes us question, why is it that we are not accepting these students into the school? Is there a limit due to financial burden? Is it due to a lack of mentorship? Is it due to difficulty with test scores? These are some of the issues that we have to consider when we think about how we may be perpetuating the problem. So next I want to talk about racism and implicit bias. And these two factors play into many different factors. And this isn't all inclusive, of course, but I just wanted to touch point on 3 specific factors. One is the challenge to academic talent that many of our medical students and faculty members may face. For example, in the case that I mentioned of the student who was approached and told that she was only accepted due to her race. Those challenges to academic challenge make students have to feel like they have to perform doubly as well, and it increased that allostatic burden and that anxiety that students feel. In addition, we experience microaggressions and stereotypic threat. Microaggressions can come from the patient who thinks that you're coming into the room to carry out their tray of food instead of to take their history, or from being told that your dialect or your accent sounds too Black and therefore is unprofessional. And lastly are the incidents of implicit bias that can occur within the selection process. And I mentioned in this particular slide a couple of studies, one that showed that in AOA, which is an honor society for specifically that is for allopathic medical students, that although stratified for USMLE stores and having the same background in community service, Black students are accepted into AOA at a much lower rate than white students and as well as Hispanic students. And below that, this particular study looks at the applications for residency and the language that is used by deans when they are presenting students to these residency programs. And it found that Black applicants are more likely to only be described as competent, while white applicants are more likely to be described as stand out, having ability, or outstanding. So these aren't things that many of our deans or professors or those who are in charge of our selective process may think about, but it is something that we need to be prepared for. So last is the minority tax. And for those who are underrepresented minorities themselves, they understand what the minority tax is. It is the additional responsibilities and challenges that are placed on our minority students and faculty that is used in the name of diversity. This tax can come in the expectation to assist in diversity efforts, the additional mentorship that's expected, the inequities that come from the selection processes, as I mentioned in the past slide, and the racism and isolation that they feel. And all of those create an additional burden on top of the burden that comes from just being a medical student as well. As medical students, we all want to perform at our best so that we can present ourselves at the top of our class with consideration for residencies, and then for medical students, they want to do the same to come into medical school. So when you add all these extra loads, it is an additional tax that these students are feeling. And this isn't to say that we should turn away those efforts, but we do need to make sure that we are looking at our students, who in this case I would like to look at as the patient, as some additional background and in the history of what's really making up the issues that we face. So now I want to think about the fact of institutional racism, and all of us to think, are we an institution of racism? How are our medical institutions perpetuating systemic racism and social injustice? And there are many factors that can happen. It can be due to the misrepresentation of medical students and pre-medical students, as well as faculty and staff when it comes to recruitment. It can come within our curriculum that can sometimes be seen as lacking cultural responsibility or being honed in a race-based instruction. It can be due to the poor mechanisms for bias and discrimination reporting and the lack of bias and microaggressions training that we give to our faculty, staff, and students. And also it can be looked at the lack of ODIs, or Office of Diversity and Inclusions, and the lack of safe spaces that our students feel that they have within the institution. Now, when we talk about these admissions, one of the highlights that I wanted to make is focusing on, of course, the African-American student, and the fact that although we are 14.6% of the US population, we only represent 7.4% of the applicants, and then 3% of the matriculants. That's less than half of the students that actually apply that are matriculating into osteopathic medicine. And not to have to compare us to our colleagues in allopathic medicine, but we are lagging behind in our diversity efforts. And that is something that we need to be able to reflect upon. Next is looking at our safe spaces and supportive environments. And this particular table actually came from a survey that AACOM gave to its colleges of osteopathic medicine, and finding that only 45.7% felt that they had a safe space for their minority students to feel free of bias, conflict, free of criticism, and free of any potentially threatening actions. And that's either a physical space or a group in which they have that safety. And next is the culturally, if we have a culturally insensitive curricula. And what is a culturally insensitive curricula? Some examples can be a curriculum that neglects to teach students about different dermatological presentations on different skin colors, not knowing what Lyme disease looks like on a Black person or on a Latino skin or a darker skin can really make a difference in how we treat our patients. Defining illnesses as Black diseases without really looking at how racism and social injustices play into those health disparities that we find. Utilizing race-based medicine, such as the coefficient of GFR for Black skin, which has been found years ago in recent studies to not have a true scientific basis, but we still use it and we still teach it. And also the lack of cultural and structural competency within our curricula. All of that really plays into how we're preparing not only our students to treat our patients, but how we're allowing our students to treat each other. And lastly is the Office of Diversity and Inclusion. And as I mentioned before, we are lagging behind in this particular piece. Only 31.4% of our colleges of osteopathic medicine report that they have an Office of Diversity, Equity, and Inclusion or equivalent in 2018. And this is a complete detriment to our students. Not only does these offices of diversity encourage collaboration. It encourages our students to know how to deal and how to respond to different cultures, to different ideas, to different patients who don't look like them. And it also, it continues the narrative that these students, when they come in and don't look like the rest of the students, are of an other, and it continues that feeling of isolation that our students have. So where do we go from here? One of the things that we wanted to do in this presentation, or what I wanted to do in this presentation, is not to try to give all of the answers, because we don't know what the answers are yet. Right now, we're just here to really look at what the scope is and ask some questions. So as I close out this presentation, I just wanted to ask a few questions. How do our institutions contribute to systematic racism? What can we do to better support our students? Are we actually prioritizing diversity? And what can we do to make sure that our efforts are more effective? So as I close this out, I just wanted to say that our actions really will speak louder. While we commend our institutions for having made these statements of solidarity, I would like to challenge not only our schools, but our governing bodies to take the next step in combating racism. Do not allow these statements to remain empty. We have to make sure that we are calling each other to action. Our students are the next generation of physicians and healers, and they are the future of medicine. And what we do now will really determine the outcomes of not only our lives, but the lives of a large number of patients in the near future. Thank you.
Thank you, Chantel. Dr. McDade?
Okay, thank you. Well, Chantel really did a fine job in setting up the conversation that we're going to have from my perspective of the ACGME. She is spot on the observations she made, and I really appreciate the cases that she presented. So the guiding principles for ACGME around diversity and inclusion are really just three. The first is that health equity is a means to achieve elimination of healthcare disparities, which is our overarching focus. And the way that we're going to approach this at ACGME, since we're the accreditor of training programs, is to work on a workforce issue. And the goal of workforce diversity is to achieve health equity. And then finally, we're going to focus on some of the things at the end that Chantal was talking about around inclusion, which are the things that she described. And we see inclusion as a tool that ensures that diversity efforts are successful. And if you put those together, it really shows why each is important: diversity, the workforce itself, as an elimination tool for health equity. And what Chantal so elegantly pointed out is what happens when you increase diversity in an environment that's unaccustomed to it. And so what you have to understand is that these environments that only have 3% African Americans or 6% Latinx trainees aren't primed exactly to be welcoming environments. And so we have to figure out how to mitigate cultural underexposure and indifference, and how to limit and cease stereotypical projections. And then we have to figure out how to reduce the environmental triggers that feed imposter syndrome, as she mentioned in her talk. And then we have to address uncivil behavior immediately and think about models of restorative justice so that the person offended, as well as the person who may have inadvertently made the offense, can both grow from the experience. The problem, of course, is that mandatory training in cultural competence, or mandatory training in implicit bias or diversity education, often engenders resentment and resistance in the environment in which you're trying to drive change. And one of the things that we have to really think about is how we can best reach the learners to try to change their behaviors. And we also have to figure out what the situations are that warrant a specific type of training that's going to be effective in bringing them forward. For instance, if you wanted to do implicit bias training, you really might want to focus on situational implicit bias training, such that people who are writing letters of recommendation or performing evaluations of students are part of the group that's really touched here. If you're looking at trying to develop a diverse faculty, then search committees should have implicit bias training, but that may not be the same as implicit bias training in a clinical situation. So I think you have to do specific sorts of training to try to address the specific sorts of problems that you're trying to achieve movement in. But this is work out of Yale, colleague Darla Spence group, and they actually asked a question of medical students around whether they experienced discrimination and mistreatment in their programs. And this comes from the AMC graduation questionnaire from 2016-17. And what they found is that compared to white and Asian students, underrepresented minority and multiracial students reported higher rates of mistreatment. And the group that actually had the greatest prevalence of mistreatment were underrepresented minority female students who bear the burden of both racial discrimination as well as sexist discrimination as well. And a study funded in part by the AACGME, and that involved the combination of the American College of Surgery, the American Board of Surgery, and AACGME. Carl Bill out of Northwestern, his group, formed the first trial, which was really focused on looking at work hour, duty hour issues in surgery, but also asked questions specifically about discrimination and abuse. And this really landmark paper last year in the New England Journal showed that we could sample, or that they could sample, 99.3% of all surgical residents. And what they found by that almost complete sample is that almost 32% reported discrimination based on gender, 17% reported racial discrimination, another 30% reported verbal or physical abuse, that 65% of women in surgery reported gender discrimination, another 20% of all surgery residents reported sexual harassment. And that the people involved in this vary from patients and families to other resident colleagues to attending surgeons. They followed up with a paper looking at that racial discrimination component, and they found that of the folks who reported racial discrimination, that it was higher in African-American trainees than any other group. And that when you looked at what was seen as racial discrimination in Blacks, they felt that there was a different standard of evaluation for them in 38% of the cases as opposed to their white colleagues. That 16% said that they were denied opportunities that were made available to their white colleagues. And that slurs and hurtful comments were quite common at 25% of all surgical trainees who are African-American. And that over half, 62%, said that they were mistaken for non-physicians in their environment. And that even by their team, they were mistaken as another African-American person who may have been in the surgical training program at over half, 55.8% of times. The idea that minority students have a different experience than majority students in medical education really is pronounced in Lottie Derby's work out of Mayo, in which she suggests that if minority students are measured in their Maslach inventory scale, a measure of well-being, compared to their majority colleagues, that minority students actually have a better Maslach score, less burnout, than their majority colleagues. However, if those minority students have been the victims of discrimination or witnessed discrimination, their Maslach scores are much lower and they're more accelerated to burnout and depression. When you look at the sorts of things that minority residents have experienced in their training, they've reported, this comes from about 14 years ago, published in the Journal of the National Medical Association, where they asked residents what their experiences were. And they talked about discrimination, these differing expectations that we saw in the Bill Morio study, social isolation that we actually heard Chantal talk about, and then career consequences for the similar sorts of things that colleagues do and how they have to develop different coping styles. And one of the things they said was that overt discrimination was rare, but participants in that study believed that Blacks were punished more harshly for the same transgression and expected to perform at lower levels than their white counterparts. They also felt that racism was at the core of many of those things that were used as critiques of their performance. And it tempers their imposter syndrome, their self-doubt. In an update of that study back in 2018, the group out of Yale again looked at the experience of minority residents in training and found that they were subject to a daily barrage of microaggressions and bias, and that minority residents were tasked as race and ethnicity ambassador in their programs. They were challenged with, again, negotiating the professional and personal while being seen as the other, even in their own groups. Lottie Derby's new work in 2019 looked at these microaggressions that minority students experienced. And what she found is that the depression symptoms that are exhibited by underrepresented minority students who've been victims of aggression of microaggressions are really driven by factors within the learning environment as opposed to individual traits. And this gets to that systemic racism that Chantal so beautifully laid out for us. And what Lottie Derby said is that medical schools need to do more to improve the learning environment for non-white students. And what happens when you are burned out? Because this is what happens when you are treated in this way in your environment. Well, your ability to focus wanes, and your engagement with work suffers. Their feelings, apathy, and hopelessness on the part of the individual who's subjected to this sort of treatment. A person may exhibit increased irritability or emotional exhaustion, or the exact opposite, potentially lability. And then there's the lack of productivity and poor performance. And when you're evaluated and you're burned out and performing this way, what happens? Well, you end up being evaluated more poorly than perhaps you should. And what we see in response to that is people who withdraw from residency program. And if you look at the bar graph here, the green being African American, the red being Latinx, remember that the number of African Americans is only about 4.5% of all residency trainees. The number of Latinx physicians about only 5%. That the number of people who withdraw, 51 out of a total of 636, is greatly out of proportion. If you look at the actual percentages, 8% of all those people who withdraw from residencies are African American. Another 6.1% over the 5% of people who are in their program are withdraw from residency in the 2015-16 year. But if you look at the people who are actually dismissed, that's forcibly told not to come back to the residency training programs, you'll see that African Americans represent a much larger number than their numbers in residency training. And in fact, if you look at the percentages of all those individuals dismissed, anywhere from 10, 11 to 20% of the people who are dismissed from residency programs are African American. And then if you look by specialty, you'll see that 25.8% of all those people who were dismissed from surgery residency programs in 2015-16 were African American. And that 40% of all those people who were dismissed in OBGYN programs and obstetrics and gynecology were either Latinx or African American. And then if you look at the relative risk of being dismissed in surgery, it's about sixfold if you're Black compared to white. In my discipline as an anesthesiologist, it's about tenfold greater if you're Black compared to white. In internal medicine, it's 12-fold. In pediatrics, it's 6.7-fold greater Black than white for dismissal. So when you look at the work of Bill Morio again, you'll see that not only is there gender discrimination, racial discrimination, there's verbal discrimination, physical abuse, there's sexual harassment, and even discrimination because of pregnancy or having a child situation at home. These all contributed by attendings, the administration, co-residents, nurses, and then patients, family, and staff. And if you look at the frequency of this sort of behavior, you'll see racial discrimination. Of the 1,200 residents who reported that they've experienced racial discrimination in that given year, that almost 900 said that they have it a few times a year, and another 368 said it happens a few times per month or more frequently. And when things like that happen, what happens is you now start driving more depressive symptoms, and suicidal ideation actually even comes into play in many situations where residents have been the victims of this sort of behavior. So the impact on the healing of having an environment that's discriminatory really has to be addressed. And one of the new program requirements the ACGME put forward last year was one to ask all programs in partnership with their sponsoring institutions to provide a professional, equitable, respectful, and civil environment that's free from discrimination, sexual and other forms of harassment, mistreatment, abuse, and coercion. And this is true of students, residents, faculty, and staff. This is Christine Porvath, who spoke with the American Medical Association's Change MedEd Conference in 2019. She's written a book called Mastering Civility. And what she did is she asked the audience, if you work in an uncivil environment, raise your hand. And a good portion of the people in the audience who work in medical education raised their hand. They showed a list of about 10 words, some of that had more aggressive sort of connotations, others less, more passive. And then she asked you to keep your hand up while you remember 4 words from the list, And when those aggressive words came up, the people who also raised their hands saying that that was one of the words that they recalled from that list were, oddly enough, the same people who had their hands up already saying that they'd worked in civil environments. And so what happens with incivility is that people miss information that's right in front of them. And those around incivility are more likely to have dysfunctional or aggressive thoughts and be unaware of the connection. And that the cost of incivility to your business is really more than you know. And people experiencing incivility may struggle to get off the sidelines and back in the game. And isn't that the sort of thing that when you're evaluated would actually prove to be negative? So now we bring it in the context of COVID. So now you've got doctors who are on the front lines who've been fighting COVID, who see a disproportionate impact on minority communities. They're taking care of folks in unprecedented numbers who are dying, sometimes alone. That takes a toll, drives the person to increasing levels of burnout. And now you add and superimpose on that the things that have happened most recently with the unprovoked deaths of African Americans at the hands of law enforcement community. And this woman in the corner here, Jasmine Marceline from the University of Nebraska, she says that she's cried frequently and been irritable, those sorts of things we describe with burnout, been neglecting most of my non-patient care duties, withdrawn from social media and virtual socialization with friends, exhausted physically and emotionally. It takes a tremendous amount of energy to walk this path, still put on a brave face, and pretend like nothing is wrong. Our physicians shouldn't have to do that. The impact that this sort of behavior takes on those individual healers is tremendous and very personal. And I really think that as institutions, we have to do something to address this next generation of physicians. As Chantal points out, that is happening in medical school. We see that it's happening in residency, and it is truly also happening to our faculty and folks who are in practice as well. So thanks very much, and I'll pass it on to the next speaker. Thank you very much, Marcine.
Thank you, Dr. McDade. I just want to remind our audience that we welcome any questions that you may have during the presentation. I would like to next invite Dr. Rossley.
Well, hello. Thank you, Dr. Kane, for inviting me to be a part of this discussion. The title of or our charge is to find a cure, reflections on racism and injustice in the American healthcare system. That's really an ambitious and intimidating charge. So what I hope to do is to cut it down to a manageable size, and so that we were able to relate to it and come up with some strategies for action. Medical education is the topic that I'm going to present. And in medical education, we have the responsibility and obligation to develop the physician workforce to meet the healthcare needs of the populations we serve. But let's start at the beginning. When we talk about a healthcare system, that's a misnomer. The reality is we don't function in a healthcare system. It's a non-system. It's composed of many mutually dependent yet independent collaborative stakeholders, which makes it very difficult to get your arms around a problem as broad and deep as racism. But we do have measurable outcomes that we identify as healthcare disparities that let us know and identify for us the fact that racism is alive and healthy in our healthcare delivery. But racism has a three-headed etiology. And racism in society also exists in the healthcare that society receives. And it occurs in three forms. It's explicit racism, systemic racism, or implicit bias. Those are the categories that we have devised to be able to explain and address some of the challenges of racism. Contributing to a cure for racism in healthcare requires that medical educators own their piece of the problem. Because although we don't control the entire system, we do have a significant and pivotal piece of the problem. So let's go through an assessment of systemic racism in medical education. And we all are aware of the systems that exist in our institutions. This assessment may necessitate us revisioning what we do, certainly innovate how we do what we do, and finally enhance the existing systems, policies, procedures, and regulations that currently exist in our processes. So let's start with student recruitment. The problem is the pipeline. We know it's the pipeline, but we also know that in order to increase the pipeline of minority students, particularly African Americans, we have to grow our own. And many of the institutions have started programs, BSDO programs, all kinds of pre-matriculation, post-bac programs. But still, that doesn't address the problem. We must go deeper. And we need to look at recruitment as a strategy for innovation in order to increase the diversity in our institutions. The second system is student admissions. And I'll be a little bit provocative as I talk about student admissions. We all use the MCAT, but we only focus on the numbers. We don't use the information that the MCAT gives us about the preparedness of students. That disadvantages students and that come from institutions that are not indeed increasing or allowing the students to be competitive. It is important for us to understand that the MCAT is a test of competitiveness. It does not identify quality. I constantly interact with leaders of major academic institutions who say we would admit more, minorities if we could find some qualified minorities. Well, the reality is they're using MCATs, and being qualified, it's not the same as being competitive. The MCAT is set up to compete for the number of seats that are available in our medical education system. It does not tell us who is or is not qualified. And I would suggest that our institutions look at the MCATs differently. Look at the MCATs to give us information that will allow us to be much more effective in promoting a more diverse student population. Classic in admissions are the interview processes. And we need to focus on some of the implicit biases that are incorporated into the interview process for admission. It's those biases, quite frankly, that limit the ability of some of our students to gain admission. And then a third system that we all spend much of our time and our faculty effort on is curriculum. The issues of racism and bias need to be integrated into our curriculum early and continuously. It must be seen as a priority and an important issue for the students as they matriculate. And that's for all the students, not just the minority students. We need to promote and present population health, cultural health, and healthcare disparities as an important part of our curriculum, both in the didactics as well as in our clinical skills courses. And we need implicit bias training for all students, faculty, and staff. And that training must be included in our consideration for appointments and promotion of clinical adjunct faculty, because our clerkships are really apprenticeships, and the students model themselves after the preceptor or the clinical faculty that they're assigned to. And it's important, therefore, that these faculty also have training in implicit bias. And one of the areas in which our students are having a difficult time, particularly the minority students competing, are on some of these specialties that are very competitive. But our students spend a large part of their fourth year in audition rotations, and we need to make sure that our minority students are able to get those kinds of audition rotations as the other students as part of our matching process. Finally, number 4, we have to, one of the systems that we have is a mentor system. The effectiveness of that mentor system is questionable. We need to formalize as a faculty effort assignment mentoring, and we must include advocacy in the mentoring system. Finally, and this is one that it's interesting to me, it surprised me both in 2 of the colleges that I was dean of, and that's clinical services. We have to establish as part of our clinical service delivery a model of anti-racial healthcare delivery. I can tell you in 2 of the schools in which I served, the faculty came to me and requested that the waiting room be divided in 2, or a separate waiting room be set up for Medicaid patients. My question was why? And it's because they said, you know, the insured, the private patients don't want to sit in the waiting room with Medicaid patients. And I was trying to figure out, how would they know who was Medicaid and who was not? So I asked them, what does a Medicaid patient look like? And the reality was they were referring to minority patients. So we have to model what it is we want to have happen in healthcare and in clinical service delivery. And we also have to establish a physician assessment of the patient as a proactive feedback to address their own implicit biases. And by that I mean, you know, we have the patients who provide feedback and patient satisfaction on their physician interaction, but our physicians also have opinions of the patients that they serve, and sometimes forcing them to identify what those opinions are makes them, or allows them, or facilitates their being able to face their own implicit biases. So we have systemic issues that we can address to improve and to promote a cure for racism in healthcare delivery. But when it comes to implicit biases, those are the everyday little cuts, you know, death by 1,000 cuts. We devalue our students and our patients. We disrespect our students and our patients, and we establish lower expectations for performance of students and for compliance of patients through our own implicit biases. Having said that, you've heard a lot of the data. The problem exists. There's no denying it. We have to resist the temptation of going back and trying to define the problem again. It's there. Today's conference, and hopefully the actions of AACOM, will start to move the ball down the road. The time is now for action. What is the next step? What do we do? How do we assess these systems that we have and their impact on the problem? So I want to close by saying it is time for us to own our piece of the cure. Thank you. And I'll turn it over to the next speaker.
Thank you, Dr. Rossley. Dr. Coffey, you're next.
Okay, thank you, everyone. I'm going to try and share my screen. I am so honored to be a part of this conversation. I always learn from these conversations. So I just really want to thank each one of the presenters that went before me, and also thank Dr. Kane for inviting me to be a part of this. I'm going to spend a little tiny bit of time talking about social work, because in my experience, even though we've been a profession since the turn of the last century, there's still lots of misconceptions about who we are and what we do. So this is just gonna be a thumbnail sketch. I'm not gonna spend too much time in teacher mode, but I do wanna do this just to provide a little bit of context for some of the remarks that I have following. So one of the things that I wanna say, and I don't have data in these slides, these are just prompts for me to think about bigger concepts. One that I would say fundamentally, social work is about thinking from case to cause, meaning that we're change agents and wanting to help and assist individuals, families, and communities, but we're always looking at where we can also influence and be change agents for policies and systems that are not supportive of health and well-being of the families and individuals that we're working with. So we're not just working on case by case by case, but we're looking at some of those root causes. A little bit of a history lesson. To the left is Jane Addams, and to the right is Mary Richmond. These are the established known founders of the social work profession back in the late 1800s and early 1900s. And they really represent the two streams of social work. So Jane Addams was very much associated with the settlement house movement in this country. I think very, very connected to some larger social movements that social work has been involved in. So, you know, ending child labor, looking at sanitation, really big public health movements. And Mary Richmond is the other side, where she was very much interested in working with families, and it was a case study approach. So it's always been interesting to me that it was Mary Richmond who was really focused on individuals, who said famously, the good social worker doesn't go on helping people out of a ditch. Pretty soon she begins to find out what ought to be done to get rid of the ditch. And actually, I think she said to get rid of the damn ditch. So that's just a little bit about who we are. And I would not be doing my job at the Council on Social Work Education, which is the AACOM for social work education programs, if I didn't just put a plea in for anybody who is at a school of osteopathic medicine or in a medical practice. If you are not connected with the schools of social work in your area or in your same institution, or have social workers on your interprofessional team, I would recommend that it would be a good idea to do that. So I was asked to think about how racism is affecting our societal health, which is no small task. And I've put up this book cover from Ibram Kendi's book, How to Be an Anti-Racist, and really looking at the challenge to, you know, the opposite of being racist isn't not racist, it's being an anti-racist. And if you're not an anti-racist, then you really need to think about ways in which you're complicit in and supportive of racist institutions and practices. We're experiencing what I would say is a very long overdue reckoning about the effects of institutional and systemic racism in this country. And I hope that we have the will to see this through more deeply than we have in the past, because what needs to be changed is not window dressing by any stretch. We really need to be willing to examine very critically the institutions and systems that we are in fact a part of, have been raised in, have been educated in, work within, and so forth. We need to be able to examine ourselves, that this is not just a matter of identifying some of those bad actors perhaps, but really looking at a systemic problem. There's a group of people that have advocated for a while for racism to be named in the Diagnostic and Statistical Manual, which is the sort of Bible of mental illnesses. Because the argument is that racism is a mental health problem. And I want to say that while some racists might have mental health problems, racism is actually a public health problem, and it needs public health approaches. So it's much broader than that. And it's tempting, I think, to look at some individual bad actors, but we would not be making the kinds of systemic changes if we followed that approach through. The truth is that during this reckoning, I know that Black and brown people have not been surprised that racism still exists. You've heard our previous speakers speak to that. In fact, racism has been alive and well. Black and brown parents have needed to talk to their children about how to survive in a racist system. You heard some of that from Chantel in terms of, how Black students and brown students are sometimes taught that they need to be better than or work harder than, they need to be the examples of in order to be seen as just as good. So we've put a tremendous amount of pressure on our students of color. It's also, there is the conversation among many Black and brown parents where they need to have a conversation about, in order to stay safe, quite frankly, to stay alive, these are the ways that you need to act. And that is such a sad, sad fact that parents have to have that kind of conversation with their children. But that is exactly the kind of system and society that we've been living in. And we have an opportunity to change that. When I was thinking about my remarks, I remembered a dear friend of mine, Larry Davis, is the former dean at University of Pittsburgh School of Social Work. And he has written about and spent a lot of time talking about the whole concept of resiliency, which was a concept that we all sort of fell in love with a few years ago, that we needed to understand how people who have been through difficult, challenging times and survive, what can we learn from those people so that we can sort of inoculate others, can build our resiliency, skills and muscles and so forth. And his take on all of this is that it should not require anybody to be extraordinary to be successful. That resiliency, even just the concept, kind of turns things around. It's like, okay, so let's reward the ones that somehow managed to survive the racism, the abuse, the implicit bias that we just heard about. I mean, just any number of explicit and implicit barriers. That is not the way to address a problem. It's really looking at what system requires extraordinary reactions just to survive, just to be successful. That's the kind of, that's the approach that we need to take with all of this. Most of the efforts that we make in the healthcare system are downstream. So, to harken back to Mary Richmond's quote, we look at treatments and interventions and things when people have presented as needing our assistance. This effort is going to require us to move upstream, to really think about the kinds of ways in which our systems have been built to only support wellness in some people and to make that more challenging for others. This is not just a matter of access and quality of health. It is also about the ways in which we have baked all of this into our systems. Thrilled that our healthcare professions are all talking about the importance of social determinants of health and looking at ways in which we can rectify health disparities. In the words of one of the deans in the School of Social Work that I work with, looking at these days to talk about the need for diversity and inclusion, and this is all due respect to all the people that have talked about diversity and inclusion seriously, but this one dean said, it's kind of like sounding like hearts and prayers. Our love and prayers are with you right now. Like, we need to do better than that. It's not just about diversity, but it's becoming the anti-racist that Ibram Kendi is really challenging us to be. I was part of a panel recently, and there was an African-American woman on the panel who, after speaking for quite some time, she just sort of sighed and said, you know what, being Black in this country is a pre-existing condition. Right there, she said it. It's a pre-existing condition for a number of things that make it more challenging for her to live her life fully and well and connected and all the things that we care about. So I just want us to think about that. Social determinants of health, in my mind, has always been a bit of a code for race and poverty. That those that are affected by the social factors that impede a full and well-lived life are factors in the lives of more Black and brown people than any other, and we need to be thinking about that. In order for us to move forward, and I'm going to keep my remarks because I know that this program has gone on longer than Dr. Kane originally intended, and I know that there are lots of questions and comments, but in order for us to be able to move forward and not lose the will for the kind of structural change that I think we've all been talking about here, is that we need to be able to engage in some non-defensive and dispassionate conversations about these things. One of the most powerful metaphors that I read years and years ago now was Beverly Daniel Tatum in her book, Why Do All the Black Children Sit Together in the Cafeteria? By all the Black kids. And she talked about racism being a smog, that in certain weather conditions, smog is very apparent. There are times when I'm out in the West Coast where you see more smog than on the East Coast, and certain humidity factors and what the barometer is doing, I mean, it's very apparent, it's visible. But there are other days when it looks like it's a clear day, but we're still breathing in the smog. That's exactly what racism is. When sometimes it's extremely apparent, and sometimes it's just in the air that we're breathing. So it's never just going away. And it would be tempting for us to think that we can just do some window dressing kinds of changes and then we'll be good. But I don't think that we can afford as a country to do that anymore. I feel like we really need to be able to fearlessly examine ourselves and our institutions in order to make the kinds of changes, to make the principles of this country a reality for everyone. And that has not been the case. It's going to be hard. It's going to be very, very uncomfortable, and we don't like to be uncomfortable. We don't like to make other people uncomfortable. But I think that that's what is going to be required for all of us, and we can do that. I mean, we will create the world that we want to create. And so what's really on the line right now are our values. So I hope that this is not a Groundhog's Day, that tomorrow we wake up and everything's the same and we get to start over, but we have an opportunity to really create a different future for all of us, and for our children, our patients, our communities. So thank you. I'm looking forward to the final speaker, and I'm going to pass that on to, I think it's Dr. Smedley now.
Yes. Thank you, Dr. Coffey.
Thank you. Really very honored to be part of this excellent panel. I thank AACOM for convening us. I want to talk about racism and health broadly, but I was also asked to talk about racism and mental health. I am now at the American Psychological Association, but I've spent many years in public health and health equity circles. So while it's clear that racism has a powerful impact on health and mental health, I want to encourage us to really work upstream, as many of our speakers have alluded to address the structures and systems that create illness in the first place. So let me just review a few key points. Clearly, experiences of racism and discrimination are related to depression, anxiety, and many other mental health challenges. And of course, during this pandemic of COVID-19, many families are experiencing enhanced stress, but this is particularly true for families of color. In our most recent American Psychological Association Stress in America survey, we found that 55% of African Americans are reporting that discrimination is a significant source of stress for them, up from 42% just a few months ago, clearly related to some of the overt expressions of racism and intolerance related to the pandemic, as well as other economic and fears about contagion of the virus. Racism-related stresses are also associated with chronic disease, hypertension, heart disease, etc. Racism is a public health problem, as our speakers have said, so we need to be very clear about that. We also need to be clear about what racism is in order to tackle those challenges, which I'll get to a little bit later. Many of the determinants of health and mental health are the same. People need access to high quality, timely, culturally excellent care. We need to address geographic and financial barriers, which remain despite the Affordable Care Act and its highly uneven enforcement. We recently saw good news in that telehealth is now expanded to include mental health service providers. Critically important as we see a coming mental health tsunami related to social isolation and economic anxieties during this time of pandemic. But we also need to be thinking and acting at structural and institutional levels. Some years ago, I was very honored to work at the Institute of Medicine. I served as study director for the report that was entitled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. Many of you are familiar with it. It really rocked healthcare providers, educational institutions, with the reality, the realization that overwhelmingly the research shows that people of color receive a lower quality of healthcare on average relative to white patients, even after we control for differences in insurance and income access-related factors. The IOM committee deliberated about what might cause these factors, and we found that disparities were due to things like uneven insurance. We all know that there are tiered levels of insurance coverage, higher quality versus lower quality coverage, people of color disproportionately clustered in those lower tiered plans, and that's if they're lucky enough to be insured. Still, people of color are disproportionately uninsured, limiting their access to care. Medical apartheid, the reality that healthcare remains separate and unequal, is a factor that the IOM report also alluded to, but the evidence since Unequal Treatment's publication in 2002 has grown that these structural inequities abound, related to not only insurance status, but geography. Place matters. Overwhelmingly, the systems that serve people of color are under-resourced and face many challenges, particularly with the growing health care burdens imposed by the COVID pandemic. It's also true that biases are clearly a factor, both explicit and implicit biases. And when the IOM report concluded that implicit bias was part of what infected the clinical encounter, many health professions were indeed shocked by that conclusion. But clearly, bias and implicit bias, as we know now, plays a part in almost every human being's life. All of us harbor biases. Our challenge is to surface those biases to mitigate them. Clearly, implicit bias plays a role. We now have a large body of research showing that biases do in fact infect the clinical encounter based on race, based on gender, based on many other factors. But it's also true that these biases can be fomented or encouraged in certain systems. And I especially appreciate the conversation about situational biases earlier. These biases are more likely to happen in stressed systems, systems that have few resources to order testing, diagnostic testing for patients, time constraints, and the complexity, the cognitive complexity of patients' concerns. All of these kinds of conditions are more likely to bring about implicit biases on the part of providers who are trying to fill in missing information. Very proud that that IOM study resulted in a number of important changes, such as changes to curricula in health professions education institutions. But we need to do much more as health professions organizations to address those structural and institutional factors that are really at the root of racial and ethnic health inequities. Healthcare only accounts for about 10 to 20% of population health, as many of you know. We need to address the social, economic, and environmental factors which are at the root of these inequities. Dr. Ross Lee, I believe you are from Detroit, as I am. I was born there in 1963. When I was born there, I lived in an integrated neighborhood, which quickly became all Black by 1970. White flight left Detroit with a suppressed local tax base, under-resourced schools, disinvestment, and this is too common in metropolitan areas across the United States. This disinvestment, coupled by residential segregation too often enforced by policy and practice, and maintained to this day by discrimination in the housing market, is something that we health professions need to confront and tackle, because it's at the root of our challenges related to the pipeline. If we can't harness the talent of our young students of color because they're attending under-resourced schools, then we all lose. And too often, frankly, we health professions are competing against each other for those students who are clearly talented and have the preparation. The problem is that we have not recognized the talent of our students of color and invested accordingly. So we've got to understand racism for what it is. I'm a fan of Dr. Kamara Jones's definition of racism. She says racism is a system which assigns value and allocates opportunity based on what you look like, your skin color, your hair texture. In doing so, it unfairly disadvantages many, many people who could be contributing to our society, and unfairly advantaging others, but therefore contributing to a waste of resources for our entire society. In my own writing and thinking, racism operates at 4 levels. I know there's some disagreement, but I want to make a bit of a distinction here. Racism operates clearly at interpersonal levels. We see that every day. We see that with evidence that the name on a resume can influence whether or not a job applicant can get a call back. I'm referring here, of course, to the research showing that African-American sounding names are less likely to get job interviews and subsequently hired. We also know that there's discrimination in housing markets. Audit studies show that pair testers, one white, one African-American, for example, given the same financial background, fictitious of course, the African-American pair tester is more likely to face discrimination, whether it's in regard to renting a property or receiving a mortgage. So segregation is maintained today, and that's a structural form of racism, in my view, because it helps to prop up systems of inequity and maintain racial inequality. Institutional forms of racism are policies and practices of school systems, law enforcement, healthcare systems that, while facially neutral with respect to race, nonetheless help contribute to disparate racial and ethnic outcomes. So we need to be constantly monitoring for differences in access and outcomes to see if racism is operating here. And finally, there's internalized forms of racism. You all may remember the famous psychologist, Dr. Kenneth Clark, who performed the famous doll study test in the 1930s and 40s. This research revealed the depths of internalized racism among African-American kids. When white and black kids were shown a brown or a white doll in these tests, they were asked, which doll is the nice doll? Which doll do you want to play with? Which doll is the better doll? Invariably, all of those children pointed to the white doll. So this kind of research, sadly, can be replicated today with the same results. We as health professional organizations need to come together to be clear about how racism operates. I'm less concerned about individual acts of discrimination. Discrimination persists, but we've got to focus our attention at structural and institutional levels as well, and be thinking about how our behavior in those systems helps to prop up those forms of racism. I thank you so much for this opportunity to speak with you all and look forward to the discussion.
I want to thank everybody for spearheading the conversation we're about to have with our audience. There are quite a few questions that we'll get to now. There was a question about, it was mentioned a couple times that we as osteopathic medical programs are behind our allopathic counterparts. in terms of racial diversity and representation in our student bodies. What do you all see as the major factors leading to this disparity, and what steps can we take to begin rectifying it?
I'll take the first crack at it. I mean, this is really a broad question that I think is going to demand a fair amount of work from a number of different sectors. I think that what we find in many situations is that people would like to change in some sort of way, would like to make the structural changes that are necessary, but haven't really done the careful assessment that's necessary to identify what those structural barriers are. A process that we've engaged in recently at Acgme was to look at reverse ideation, which is instead of seeing the weaknesses in the learner or the weaknesses in the process that the learner is in, to see those things that are actually problematic in the structure of the different levels that the learner is subjected to. So for graduate medical education, what's the specialty thinking about in terms of how to address this problem? What's the sponsoring institution and the clinical learning sites doing to impact that learner adversely? And then again, what is the actual program doing? Are there individuals within the program who are problematic? Is it the structure of the program? Is it the lack of diversity among the people who are involved in selection and evaluation? Is it that people who are coming to work with the no intent at all in a cognitive fashion to discriminate? Is there just living in an environment that is structurally racist and is founded on supremacist ideologies? How do you take that hat off when you're evaluating a resident of color without saying that, without thinking at least that could be a factor that evaluates your thinking? So it's a curriculum, I think, that we have to develop for programs and for institutions to think about what they're doing to our learners, medical schools, what they're doing to our learners, and not really focus on so much what the learner needs to do to strengthen and to somehow change. When you're thinking about the MCAT, for instance, as Dr. Ross Lee spoke, we're looking at deficiencies in the learner. Well, let's look at what that test is actually testing. And what's the downstream sort of impact of losing people who are excluded because of that? If you look at the data from AMC, you'll see that under half of the African-American men who take the MCAT actually end up applying to medical school. That means that there's a huge resource of people out there that could be directed into medicine if we knew how to channel them there. Is it that they're looking at the wrong materials? If they're looking at averages, that you look at the MSAR, the medical school admissions requirement that AMC puts out, a requirement book, they don't publish the range, they publish the average. And so if you have a minority student who's looking at that and seeing just the average and not the range, they don't realize that most of the African Americans who are admitted are in the lowest percentile of people who are admitted to medical school, but they still get admitted to medical school. And they go on to become fantastic physicians afterwards, because MCAT, as Dr. Ross Lee says, doesn't really measure the quality of the person who is actually going to go out to become a physician later on. It's easy to measure, and so that's why we measure it. We have to think deeper than that and more broadly than that.
So on that same topic, how do we change the schools from valuing the MCAT grade so highly? How do we shift their thinking?
Well, if nobody else wants to go for it, I'll go for it too. Barbara, you're in.
Yeah, well, part of the issue is we evaluate institutions based upon their MCAT average score for their classes, which becomes a disincentive to deal with the MCAT in the ways in which the MCAT can be dealt with to identify qualified and potentially excellent physicians. So we have to look at the incentives that exist for institutions to do the kinds of things that they're doing, because in order to change, you have to be willing to challenge those incentives. So if you said, hey, I don't want to be, I don't care if I'm number 200 medical school based on MCAT averages, my students will ultimately all graduate and be excellent physicians. But you got to be able to to take that gamble. You've got to be able to take on that challenge of not being held hostage to the incentives that external bodies have imposed upon you.
There's a follow-up question, Dr. Lee. Can you share your solution pyramid as you've discussed before with other attendees?
Okay. Well, you know, we've studied this problem. We know it exists. We continue to study it. We get deeper, we get broader. The issue is, when do we get action? And part of the reason why is there is a decision pyramid, an engagement pyramid. And first is, we have to understand there is a problem. The second one is that we have to understand the problem. Then we have to, there is a problem, we understand what the problem is, but it doesn't affect us. So we have to relate to the problem. So we must know it's a problem, understand there's a problem, relate to the problem. And then you would think that we've done all that we can do. But no, then the next step is, we have to understand the solutions, and we have to be able to relate to the solutions. So in order to make change, you've got to go through those 5 steps.
Another question for the panelists is, as leaders in medicine, how did the physicians of color survive or navigate the racial discrimination, abuse, burnout, bias, and harassment during medical school and as clinicians?
I'm very excited to hear the answer to this question as a current medical student. Like to hear that from our physicians of color. I know that from my personal experience, I'm not a physician yet, but obviously I intend to be. And I find that it's really important to, number one, if the person who asked this question is a minority themselves, is to find your community. And that's where that isolation that I spoke about can really make a big difference in the survivability of a student or a resident moving forward. When you are able to find that safe place, whether that's a group or someone who you can speak to, or a faculty member or a mentor, or someone who you can relate to, or who can relate to you in this experience that you're going through, it really makes a difference towards your ability to handle that anxiety and to feel that hope and optimism in moving forward. So for me, I'm lucky enough with the institution that I attend, PCOM is a school that has an office of diversity and does have those safe spaces where I was able to retreat to when I felt like I wasn't able to express my own experiences or get help from any type of racism or discrimination that I experienced. So I do want to hand this question over to one of the physicians, since you have obviously made it through medical education at this point.
This is Barbara, and my daughter taught me this lesson. She's a physician. I tell the students, medical school is not school. It's a lifestyle. And if you can start to adopt it, to think of it that way, that you're not going to be able to do all the things that you did before, and then put on top of that the load of medical education, then you have a better chance of navigating through the system. So medical school is not school, it's a lifestyle. And you have to be able to unload some things. You can't do everything you used to do. You've got to prioritize the academics along with the social life. You just can't do it all. You've got to be able to place those 2 parts of your lives together.
So I'll speak just as a physician. One of the things that kept me motivated, I was the only African-American student in my class. I was obviously the only African-American male student in my class. There were very few other folks in school along with me. The problem, of course, is that I saw the injustices of healthcare growing up. I grew up on the south side of Chicago. I know what it was like to wait for 4 hours and bring your lunch to the ophthalmologist's office in order to be able to be seen. So the thing that really drove me is that I understood that as a Black physician, I was going to have a positive impact on a community that's underserved. And so I practiced in the same area that I grew up in when I was in practice. And in fact, I took care of my kindergarten teacher, took care of people who grew up on my street. And that really continued to provide the impetus that I needed to drive through. I wasn't trying to study for myself so that I could get a higher score in the exam and be more lauded in some sort of way. I studied because I wanted to be prepared to take care of that patient who's not going to have anybody else to take care of them.
Yes.
And that's what really motivated me as a physician, as a trainee. And although you face a lot of adversity in your training, you have to keep your eye on the prize. And the prize is that you're going to be able to provide care that no one else is going to do.
And I'd just like to add to that, you can't do it alone. You've got to partner with your colleagues and your peers. You cannot go through that process all by yourself, you know?
So as a follow-up, what do any of you do for self-care?
For me, it's family.
For me, it's socializing and also dancing and working out. I actually teach a dance fitness class. Haven't taught it in a while because clinicals have gotten in the way, but that's been my primary self-care activity.
Dr. Smedley?
Listening to jazz and cooking.
Me too. Dr. Coffey?
I have actually found during this pandemic that I've needed to adopt some new ways of taking care of myself because I need to switch things up. So I took a class about a year ago that encouraged all of us to just make a list of 15 simple acts of joy. Things that you didn't have to really plan on, that you didn't have to, do a lot of preparing for. And I turned to that list, and sometimes it's easy as singing a song, and I have an awful singing voice, but it gives me joy to give it a try, or turning on Bill Withers' Lovely Day and doing a little dance around the living room. So anyway, I feel like that sometimes we set the bar really high for ways in which we can take care of ourselves. And, a minute or two of doing any of these simple acts of joy is really a good thing.
Next question is, what are some thoughts and or ideas to develop a medical school curriculum on racism and go beyond DEI? And perhaps also the Dr. Coffey and Dr. Smedley can also share in your particular specialty areas what that might look like. So what are your thoughts and ideas to develop a medical school curriculum on racism or in any other areas?
I'm happy to talk about some of the things that we're doing within social work education. We convened a task force to really think about ways to advance a more explicit anti-racist approach in social work education. So I feel like we've been, one of our core competencies for all social work practitioners that we emphasize in the education program is about diversity and understanding the mechanisms of oppression. But I feel like we've kind of leaned more on understanding and appreciating diversity than being an explicit anti-racist. So I think we're looking at ways in which we can, infuse the curriculum with that kind of approach, do some faculty development, because there's clearly lots of these kinds of conversations can be really challenging, and we need to provide some faculty development for people to have, to invite students in to think about the kinds of conversations that they're going to need to have about this. And also thinking about developing some sort of a self-assessment for programs to be able to evaluate on the continuum of being, sort of a good to a great anti-racist program. So looking at faculty and student ratios, but also curriculum, who we're preferencing in our syllabi in terms of our readings, who's on search committees, just any number of programmatic and structural kinds of things that our programs can do to be more explicitly anti-racist.
I would agree. In psychology, of course, efforts to ensure that we promote cultural excellence. We have a long history, and we're still learning. Psychologists developed the implicit association test and have helped to kind of promote that as a tool to help understand our own thinking, and as a societal issue, how cultural representations are sort of have an imprint in our brains. For anyone who has not taken it, the implicit association test is a wonderful learning tool, and you can take the test at the Project Implicit website. And it takes about 15 minutes to take that test through any number of conditions. But I do think we need to also bring community perspectives, as was said earlier, into our curriculum, helping to inform the lived experience, particularly the lived experience of identity, be it with respect to race and its intersections with gender, economic status, and other factors. For example, the APA had sponsored a program last year associated with World Poverty Day to help raise awareness about the lived experience of poverty. So these are some steps that we can take to ensure that we're all more fluent in understanding difference. But I think that we need to do more to help us think and move upstream in our work, as I was describing earlier, in terms of thinking about how we got here in the first place with things like residential segregation, dividing our society, and creating both political and social divisions.
This is Barbara. I would just say, I think a stronger position would be not to have a separate course, but to integrate it into everything that we do, because that's the social fabric of how racism is included in healthcare. And so it needs to be integrated on a continuous basis.
Question for you, Dr. McDade. What is the etiology of dismissal in GME? Does it reflect something unique to GME?
Well, I think that there are several things that are unique about GME. And as Chantal points out, that having advocacy in the leadership of your medical school, having an office of diversity, equity, and inclusion, or some group that's going to focus and allow that voice to be heard, I think is really important in order to address it. And that doesn't exist in GME in the same sort of way. There often is no advocate for an individual who has a complaint in GME. And so I think that every program needs to have somebody who addresses this issue. I think every sponsoring institution needs to have a graduate medical education committee, the GMEC, that has a position that we've now been referring to as the Vice Dean for GME Diversity. I think that person can give a fair hearing to the folks who may be having particular problems because of a fit. So less than half of the people who are dismissed, withdraw from residency, are leaving because of academic reasons. They are leaving more because of fit reasons. And that fit problem is part of a culture. And that's what we really have to change. We have to ensure that everybody feels that they belong. And that's really the essence of inclusion. And that's what I think that an office, a person who drives this agenda within the GME community at an institution can do. My thinking around why people leave is because if you feel you're the only one and that you're being attacked in an unfair way, it certainly discourages you. And if you get discouraged in one particular residency type, then maybe you may say, this field's not for me. And that's what leads you to transition to something else. What I find is that it's interesting. I could show you data that shows the propensity to choose a particular specialty as a function of race. And some people would say, well, there's some self-selection that's being done there because these more competitive residencies depend on higher scores. Minority students don't have the higher scores, so they choose those residencies. But it's not the case, I think. I think there may be a harshness in some fields that really keeps people out of it. For a long time, people posited that women in orthopedic surgery may have had that same sort of an issue. Well, the problem with underrepresented minorities in orthopedic surgery is worse than there are for women in orthopedic surgery. So I think we have to look carefully at the specialty barriers that are there, as well as the structural things that we can fix within sponsoring institutions and programs to try to reduce that number.
Couple more questions. Chantal, you talked about this. You gave data on the absence of Black males in medicine overall, but you talked about allopathic data. Is there data on the number of Black males in osteopathic medical schools?
Thank you for asking me that. So from what I was able to research, I wasn't able to capture enough data to be able to present a good enough graph for what the point was that I was trying to drive home. And that actually points to another issue that I find within the osteopathic institutions that I think that we all can take time to address is the transparency in the data that we are collecting. Some data that I had a really hard time trying to discover was, number one, the number of ODIs, or Offices of Diversity of Inclusion, within these medical schools, the number of fourth-year graduates, the attrition data, the number of people who graduate, the number of people who are accepted into residency programs. Many of these numbers are really important for us to really capture what the issues are as far as diversity and inclusion efforts where bias and discrimination plays a part in. And if we're not reporting that data, then there's no way that we can truly try to capture what the issues are so that we can treat this problem. So yeah, to answer your question, I wasn't able to find any, but I would be happy if someone is able to bring that data over.
Okay, that was pretty much the final question. Any other final thoughts from our presenters before we close?
Okay. I just want to thank Dr. Kane for inviting me to join this group. It's been a great privilege to hear some of my heroes, like Bryant Smedley's work is seminal and important, and being here with Dr. Ross Lee was fantastic as well, and all the presenters, even the youngest of us taught me something today. So thank you very much for having me.
I too want to express my thanks. I've learned a lot and want to encourage continued interdisciplinary collaboration.
I agree. I want to thank Dr. Kane for inviting me to speak from the outlook of a medical student. Many times, sometimes we feel like our voices aren't heard. And I think giving us this platform, giving all of us this platform to be able to speak to everyone about the struggles and issues and burdens that our communities do face is very powerful and speaks towards the work that AACOM is looking to do. So I want to thank you, and I really look forward to the conversations that we have in the future.
Dr. Kane?
Well, I certainly want to thank all of you. This has been tremendous. I appreciate what each of you were able to contribute to the evening. And I hope it did exactly what I was looking for. It was the start of the conversation and much of the background, the pieces that can drive where we go. I know I was sitting here capturing both questions and thoughts that as we think forward to the adaptive work group that we are bringing together through the council, how many of these are important questions that they can begin to address and help guide us. You know, as I look at the last comment made by Chantal about just data capture and how that data is shared and how quickly and easily that's something that you can begin to resolve. And so hopefully we can look to those things and try to make a difference in the future as we move forward. So thank you, and I will look forward to our next time together.
Thank you, everyone. Have a good evening.
Have a good night.
Thank you.
Bye-bye now.
Wonderful.
Thank
Bye-bye.
you.
Thank you.
Good night.